I had a really great question. Sam, where am I supposed to go and stop with my wire? I don't really understand what the physician is looking for or when they want me to stop. It's kind of easier from a femoral approach, but from a radial approach, I'm really not sure. So let's talk about it. First of all, to understand two things. Number one, you historically here, you want your wire ahead of the catheter, right? So if this is, just do a really rough drawing here. So in blue is your catheter, so your Jackie, your TIG, your JR4, your pigtail, and then you have the wire ahead of the catheter. Keeping the wire ahead of the catheter does two things. Number one, if you have a harsh curve, right, like this or like this for a pigtail, the wire straightens that out, because when you're going through the small vessels of the arm, you don't want this curve to navigate. Instead, you want a straight catheter, right? In order to get a straight catheter, you need the wire to straighten it out. Number two is the wire is a J-tip, so it has an atraumatic J-tip. And what that means is it can safely navigate through the vessels, and if it bumps up against the wall, it's going to kind of deflect the catheter down, versus going with this open hole catheter on the end. It's like taking a chisel up against the vessel wall, which you don't want. So the wire helps with that atraumatic movement. Now, where do you want it to stop? Well, we do almost always want the wire ahead of the catheter when we're putting things in, especially when we're going blind and you're not fluoroing with where you are going. So you're going to get access in the radial artery, which is down here in the hand, right? And then we are going to direct it up to the subclavian, and this is kind of where things get a little hairy. Some physicians fluoro, some do not, and unfortunately, if you're not fluoroing, you're just going by tactile feedback. So if you feel resistance, the wire could be up against the wall or curving up where you don't really want it to go, and you're feeling a little more pressure back on your hand where the wire is. And that's where you speak up and you say, hey, can you fluoro? Hey, show me where we are, so that you can check that you're going where you want to go. Because number one, you don't want it to go down into the rema, right? Especially vessels that are small, a little smaller, the same size as the wire. You don't want to cause any of that spasm or dissection options. So you don't want it to go down in the rema, you don't want it to go up in the vertebral, you don't want it to go up into the common carotid, and you definitely don't want it to go this way and go that way to the carotid. Or, you know, best of the scenarios is it just goes down descending instead of down the ascending. That's not a big deal. But any of these great vessels or even the vertebrals, you don't want it going up there when that is not the intention, and especially when you're not looking where it's going. Heaven forbid there's a plaque or something here, you let the wire go up and then it embolizes that plaque and causes a stroke. Okay, that's kind of what we're thinking worst case scenarios. Which is why the guesswork when you're not fluoroing where you're going can be a little frustrating. So where do we want it to stop? Well, it's going to depend on the physician. Some physicians are going to want to stop in the arm so that they can fluoro and navigate and see where they're going as they're approaching the left subclavian. Others are just going to rush and go completely blind and be like, oh, where am I? So I like to stop in and around this area. But again, if you're not fluoroing, you can't see, right? You're kind of guessing where you are depending on how long their arm is. So if you get to a point and you feel a little resistance, speak up and say, hey, can you please fluoro so I can see where we're going? Or if you feel it's totally free and you fluoro up here quickly and see we've gotten past this whole area safely, now where am I trying to go? So what you're trying to do is direct the wire and catheter here in a perfect world. Now what are right here, I'm going to draw in purple, are the coronary arteries on the right and left coronary cusp, usually if the patient has normal anatomy. If they have grafts, you're going to have some stuff up here. But what I'm trying to do is get the catheter down into the ascending aorta. And normally this space is a little longer, so keep that in mind. All right, but this is the whole catheter, and remember we helped straighten that out and get that down here. Now, I'm going to stop in this area about in line with where the coronary arteries are, because now what can happen down here if you're not paying attention? If you weren't paying attention, like it happened with the carotids and the vertebrals, the wire can accidentally go into a coronary artery, or it can accidentally cross into the left ventricle. And if you start seeing PVCs, that's a really great sign. Oh, my wire went into the LV. Let me pull it back really quick. This one, you might feel a little resistance if it went into the coronary, or you might start seeing some EKG changes. Again, you want to pull that back. You don't want that in there, which is why it's important to kind of try and land right here at or above where the coronary arteries are. Because what the physician is going to have to do anyway is remove the wire in order for the catheter to take its shape. Because remember, the wire was in there and it straightened out the catheter. So in order for the catheter to take the shape, the wire is going to have to come out anyway and probably sit back here so that the rest of the catheter can take its shape and it can properly cannulate into the coronary artery. So this is usually a good place to stop. Just really work on communication. If you're not comfortable at first, or you aren't really sure what the physician wants, do you have a physician who likes to stop in the arm? You want to ask, hey, when I'm putting up the catheter, where would you like me to stop? In the arm, at the aortic root, and make them communicate to you. Here are some alternative scenarios and situations. So we talked about stopping in the arm. They might use an 014 wire instead of an 035 wire to navigate tortuosity in the arm itself, before then exchanging for an 035 or an 035 hydrophilic wire and progressing to the left subclavian into the arch, or brachiocephalic into the arch. You might have a physician who chooses catheters that ends up in the descending, and then they kind of center up the image and use both the wire and the catheter together to redirect it into the ascending. You might also have a physician who just inserts really, really quickly. Next thing you know, your wire is kind of hooked like this up against the aortic valve. Now, if you have a patient with regurg or any type of issue with aortic regurgitation, it's very likely that that wire will dip into the left ventricle because it's just a little bit more of an open space. So that's something you want to consider. If you have a physician who does rush like that, you immediately want to look, and they're not fluoroing and will not fluoro when you ask, you immediately want to look at your EKG and check for those PVCs immediately. And if you see any PVCs at all, it means you're in the left ventricle. And if you know they don't start in the left ventricle, they don't have an intention of that, you want to pull the wire back. There are some physicians who intentionally do this because they start with an LV gram with a pigtail, but you'd be going in with the pigtail and you would kind of know that. The other scenario is if you do fluoro right at the chest and you don't see any wire and you're like, where is my wire? Pan up. Is it in any of these gray vessels? And if so, again, pull the wire back so that it lands back safely into the arch or even back into the brachiocephalic again. Now, remember, everybody's going to have different expectations of you. So again, you want to get to know your physician preferences. If they're more the type of people to be conservative and stay around in the arm, use an 014 wire. Do they want you to stop in this area so that they can properly navigate where they're going? Or do they not show you anything and you might end up in the descending and just have to reposition? But also understanding what that tactile feedback feels like when you meet resistance, because you are up in something else or you did feel that the wire took a bend, you want to call attention to it, pin the wire, stop where you are, go on fluoro and see where you are located.